Hello and welcome everyone. My name is Kristen Talbot. I'm the program manager for MAVEN project. Thank you all for joining us today and our friends at Manic Community Health Center for hosting today's session, The Power of One, Improving Systems to Reduce Burnout with Dr. Carrie Horwitch. Dr. Horwitch is an outpatient primary care physician. She is also a certified specialist in care for patients living with HIV. She has been in practice for over 30 years, and for 20 years, she worked with the Virginia Mason Medical Center Internal Medicine Residency Program as an associate program director and key clinical faculty. She is a clinical associate professor of medicine at University of Washington, Seattle, and Dr. Horwitch was the governor for the Washington chapter of American College of Physicians from 2010 to 2014, and served on the American College of Physicians Board of Regents from 2014 to 2018. She's currently a member of the Board of Trustees for Washington State Medical Association. Her areas of interest are HIV, STDs, ethics, clinician well-being, and public health. In addition to her medical training and expertise, Dr. Horwitch is also a certified laughter leader through World Laughter Tour and teaches about the health benefits of laughter. And we are so very thankful to have her as a MAVEN Project volunteer. So let me pull up the slide deck and I will turn it over to
Great. Thank you so much, Kristen, and welcome everybody and Happy New Year. So Kristen is going to be advancing my slides. And what I want to say about this topic is I hope that this topic leaves you with a hope and an ability to actually make changes in your own clinic or organizations that will help you be able to thrive in your careers. Next slide, please. As Kristen already said, we now have our own CME. I do not have any disclosures. Next slide. You already heard about that. So what I hope to focus on is some quick wins that you can do for thriving, how you as one individual with your team can make a difference, and then also some of the system changes that can help reduce burnout. Next slide. I think we all know why this topic matters. We know that there is increasing dissatisfaction with working in healthcare, and this is across the board, so not just clinicians, but nurses and others. We know that when there is less satisfaction at work, that it can increase what feels like the moral injury, and I like to use that term because I think as a clinician, what I want to do is I want to give the best care possible to my patients. And when I feel that a system or things are put in my way to be able to do that, that doesn't make me feel like I am doing the best that I can for my patients. And that gives us what we would call a moral injury for clinicians. And I think that is probably one of the bigger drivers towards dissatisfaction and not being able to thrive at work. We also know that when there is higher rates of burnout, that there is actually worse patient outcomes, more medical errors, decreased patient satisfaction and adherence to our recommended therapy or practice, that there may be actually loss of professionalism or other behaviors. We actually become less productive, not more. So therefore, it actually, for the CEO group, it actually impacts the fiscal note of a practice, not for the benefit. And it actually can affect the whole medical team. So I know when we do things for clinicians that actually improve the satisfaction, we actually notice that everybody gains from that, the front desk staff, the MAs, the nurses, everyone. It is very costly to lose clinicians or anybody in a medical practice, but even primary care, the loss of one clinician can be several millions of dollars to a system. And then it also reduces the ability to actually recruit new people. And then, of course, there may be our stress on our own personal lives or our family life. Next slide. Now, we've seen in multiple things on multiple different newspapers and journals about medical care and the medical system and how it is affecting. Mostly they talk about doctors, but I would say that if you look across the board, there is high risk of concern across all of the specialties and staff within the healthcare system. Next slide. We've also seen some of the stats. There has been multiple studies Nationally, burnout rates probably range from about 40+% to over 55%. And it also actually increased during COVID. So whether that was because COVID created more stress, which it did, or whether because people are rethinking since their lives were so disrupted about the medical system. And it's also very, very, very expensive to our system. 4.6 billion in costs just due to physician turnover and clinician turnover, as well as reducing clinical hours, which a lot of people do, to be sure that they can actually sustain their practice. We already spend more than any other country in the world on our healthcare, but it doesn't mean that we actually have better outcomes either for our healthcare staff or our patients. Next slide. And we know that a lot of studies have been done to teach us about what has contributed. I am going to talk a little bit about time demands in a PDSA that we did at my practice that really helped with that. But there's also increasing bureaucratic tasks. We all do not like our electronic health records for one reason or another. We feel that we have lost a lot of control over our schedules and that we don't have as much flexibility or autonomy. And then there's just this constant pressure for increasing our volumes, and then the burden of prior authorization, which I would say needs advocacy to help do something with. Also, I think it's important that we maintain a voice for all of these matters. So as I say and others say, if you are not at the table, you're on the menu. So we need to be sure that our voices are heard and how it is impacting our patients and the healthcare workforce in general. And then it also means that we don't have as much connection to where we may work, and therefore we're not really thriving in that situation. Next slide. So again, this is just another survey that sort of shows what some of these issues are. As I mentioned, the moral injury. And I really think most of this is system-based issues. And I say that very deliberately, is a lot of emphasis and a lot of focus on wellness programs and well-being has actually been focused on personal resilience. And while personal resilience is certainly important, it is not the main issue. And actually, people in healthcare tend to be extremely resilient. And we do need to be resilient to actually do the system changes, but it really is the system issues, I think, that are driving more of our ability not to thrive. We have a lot more indirect care, so that might be our inbox or after hour time, and a lot of the regulatory changes. Next slide. So there was a study, and I'll talk a little bit about Mark Linzer in just a minute, that he did where we really don't have to have burnout if we really look at different kinds of interventions along the way. And burnout really is a long-term, constant, systemic stress that we have. We know that these stresses are predictable, and if it's predictable, that means it's preventable. So we can have interventions at some of the predictors. Once there is stress, we can actually have interventions that help with that. And then if somebody is actually not doing well or is struggling, then we need to make sure that we don't turn our back, but that we actually recognize it and get help so that they can again be back into the healthcare workforce and doing well for themselves and their patients. Next slide. Many of you may have seen the Stanford model. So this came out several years ago about what really contributes to professional fulfillment. There have been other models since then that go into a little more detail, but I like to use this just because it's relatively simple. And you can see while personal resilience is still part of that, I think a bigger part of the pie are two issues that deal with systems. And that is the efficiency of practice. So how well do our practices in our clinics, our healthcare settings actually allow us to work more efficiently and better? So that a lot of that is focused on reducing unnecessary waste. It's making sure we have the tools that we need to do our practice. It may be having standards for rooming and dealing with messages so that we don't have as much what I would call chaos. And then there's the culture of wellness, which I really think actually deserves more attention because people say they create a culture of wellness, but many places really don't. And so a culture of wellness has to actually start at the top and run all the way through. And a culture of wellness to me means that your organization and your system actually cares about the healthcare workers as much as they care about the patients that we are taking care of. Next slide. So I'd like to move away from sort of what brought us here and really try to focus more on things we can do. So sort of some positive things that I think we all could probably take away. So some of the things that we can do is we can make sure that we are looking at our own systems and advocate for process improvements, standards that work for us, working on how we can facilitate the efficiency. One of the things my organization did was we really tried to get rid of waste and make sure every single exam room was set up exactly the same, which means that any paperwork that was in there, tools, anything we would need to take care of the patient is in the room, that we don't have to go down to the supply room and grab something. And that actually got rid of a lot of waste. It also saves money. And then any room that you went into, it was the same. So you didn't have to have one room different than another room and try to figure out what was missing. So that's a very easy thing that an organization could do. It takes time and it took input from everybody to really kind of do checklists as well. What do we actually need in the room? What do we need? And how many people use it? We need to make sure that we think about helping all the healthcare team. And we need to make sure that the healthcare team is practicing at what I would call the top of their license and expertise. So really, you want to be sure that the MAs can handle enough of the care to the top of their license, that the nurses are doing it, and that the clinicians actually are spending the time with the patients doing what they do best, and less time on all these, sort of administrative tasks that might be able to be better done by others. We do need processes to help with indirect care. And of course, we always need to improve our EHRs. Next slide, please. We've all heard about the triple aim, which is to have a better patient care, better health, and better value. Next slide. And for a long time, Chris Sinski and others have been advocating that we should actually call it this quadruple aim, which is making sure that we care for those of us who care for patients. So we need to make sure that we walk our talk. We need to actually practice the caring and show it. And we need to give perhaps data from other businesses that have been able to do this successfully. Next slide. Excuse me. So how I like to think about this is what I think about when I think about system change is really minding your P's and Q's. So under the P's, I put you need to prepare. And by preparing means you may need to get data. You may need to think about or prepare what are the real thorns in our side in our practice. No change usually comes that easily or quickly, so you have to be ready to persevere and persist. And I think it's always valuable when you are trying something to call it a PDSA or a pilot program. It doesn't buy any organization into permanent long-term change, but if you can show that on a pilot or PDSA that it works and helps, then it can be rolled out to be perhaps more consistent and persistent. We need to also on our cues question our assumptions. We need to quantify what the issues are, and we need to make sure that we do not give up on the quality of our care. Next slide. So in part of the preparing, you need to get data. So you need to know what's going on in your own clinic or your own organization. And I don't mean getting data just to have it and do absolutely nothing with, because people will, that is another one of those things that causes, I would say, moral injury. As for people collecting data on satisfaction, you never hear back about it and nothing's ever done. So this is something that if you're going to think about doing a PDSA, you have to figure out what are you currently dealing with? How are people already dealing with work issues and situations. Mini Z is actually a free survey that you can use. It's more of a burnout survey, so it doesn't get to everything, but it's a good place to start just to see what you're dealing with. And then it's also something that you can monitor over time. If you try an intervention, then you can redo the survey to see if you've made improvements. There are other types of exercises you can do to identify what I call the thorns in people's sides. So these are the things that, if I have to give a list of the things that, gosh, if only I could change this in practice, and changing it will make a difference in my practice, those are the things we want to identify. When we identify the thorns, I think it's really important that we identify the things that we actually have control over in our clinic. So I don't have control over how we hire or get, list different jobs or anything like that. That's not something. We all need more staff. That is very clear. But that is not something I have control over. So I'm not going to do a pilot or a PDSA specifically for that. But if I can do things in my practice that make a difference, so more people want to stay and more people thrive, then that is actually a recruitment tool to try to get more staff and more help into the clinic. You need to make sure you have a very short elevator speech as to why this is important, and that's especially important to what we call the C-suite or the fiscal administrators, as to why this is important that we want to do. And I think it's really important, even though I call this the power of one, it is important to have somebody, a partner, in the administration, or somebody who can look at sort of the business part of any system thing that you're going to want to do, because you may need data that is looked at when you have a project in mind. Next slide. So I think it is always important to question assumptions, and I would do this in a very professional manner. A lot of common assumptions about not doing change. We can't do it. It's going to cost too much. We don't have anybody to implement it. It's not one of our institutional priorities. Oh my gosh, it's going to reduce all our revenue. It's going to reduce our patient visits because somebody decided that we need so many RVUs and patient visits. Where those numbers come from, I don't know. But I think those are actually all assumptions that I think we could question professionally and say, what is more important? That we have good patient health, and that we have our healthcare workers who want to stay here and work and continue to thrive here. So I like to use an ask, listen approach. Is ask a question, well, why do we have that? Listen to the answer and keep asking more questions to try to understand what the real issue is. We need to, of course, encourage growth mindset in when we look at ideas. And hopefully most of you know what growth mindset. So rather than always looking at the negative, we really try to say, okay, well, we might have tried that. That didn't work so well, but what we learned from that is this, and therefore we can move forward. You have to have data. And I think that is really important when you're talking, especially to the business, the fiscal, is we have to have data to offset the assumptions. So like cost too high, we're going to have reduced revenue. Those are all assumptions that data can help us contradict. And then we also need to, even if it does cost a little more money, or even if maybe there is reduced revenue, you have to look at it in the money saved, which is different than money earned. And that is that it is an investment in our recruiting and retention of clinicians and other staff. Next slide. So there's my little picture of growth mindset. Next slide. And then under the persistence and perseverance, in improv, we have this philosophy of yes and, which is really keeping us open to possibilities. We should not fear failing. And again, failure is just an opportunity to find a different path, and perhaps a path that works. So sometimes we can't do everything we want, but certainly if we are open to ideas and we yes and things, we will probably get more buy-in and more satisfaction. Encourage others to join, so those who may have a passion for this. And I think it's really important to look for the lowest hanging fruit first. Those are the really easy things. So those are probably the things you can change in your own practice that require no money, no, real change in any system. But those may be things that can be really easy that will make things easier. So I think one of the things like organizing the rooms that they're all consistent, that's a pretty low hanging fruit because really it's in your own domain and doesn't require any input from anyone else. And then, you can also think, well, what are these things that we could do that add very little, that add no cost, or that actually might reduce our cost? Next slide. And then when we look at workplace engagement, again, we want to look at the prioritizing our team. We can't do this alone, and we need to work in collaboration. We should try to enable control when it's possible. We should show appreciation. I think it is really important that sometimes in our busy days, we just forget something simple as saying thank you, or saying, I'm so glad you're here today. Thank you. Thank you for helping me today. And it's amazing how beneficial that is to people. I also think it's helpful to do what I call, hello rounds or smile. And we know that smiling is the shortest distance between two people. So I think just saying hello, smiling really helps people feel more engaged in the team and the system. We do need our leaders involved in this. So they need to see what we're doing and what the concerns are. And we want to try to build community around this. So there may be other organizations that have done similar things or struggled with certain things. So we should be reaching out, learning what did they do, what worked, what can we perhaps gain from that and try in our own. We want to recognize values. And I know a lot has been said by different organizations, really trying to get everybody to stop using the term provider. We are clinicians, we are physicians, we are nurse practitioners, we are physician assistants, we are a social worker, we are a nurse, or we are a pharmacist. When you lump everybody as provider, it really, I think, demeans what we have done and our own general practice. So in your own organization, I would really try to get them to stop using clinician. It's an uphill battle, but I would still try. I also don't think that we should be calling our patients consumers. As far as I know, not a single one of my patients wants to consume medical care. They don't want to buy surgery. They don't want to buy, their pills necessarily. What they want is care. And so I don't see them as consumers. And I think that those terms, provider and consumer, are really business model language. And I think that is not helpful to healthcare. Next slide. So I wanted to get back and talk a little bit about Mark Linzer. And he is an inspiration for me. He's one of the people that was one of my teachers for being a wellness champion at American College of Physicians and then in Washington State. And he wrote an article, which I would encourage all of you to read, which is saying that he doesn't believe a 15 to 20-minute primary care visit is enough. And we should really advocate and work on getting rid of it. Because we know in primary care, which I spent, 30 years doing, it's a long-term cognitive practice, and we need time. We need time to talk to our patients. We need time for our patients' stories. We need time to think about the issue. We need time to organize what the plan will be. And 15 to 20 minutes is usually not enough time for most of our patients. Next slide. So that paper actually inspired me for my PDSA or pilot program that we tried at my organization. And I wanted to share what our process was with you. So to me, and we did this first, I did the burnout survey. Second, I did some exercises to try to find out, well, what are our key things that we really wanted to focus on? And what came out with almost every clinician was we don't really have enough time with our patients. So most people were on what would be considered a 15-30 appointment, 15 minutes for returns, 30 minutes for new or perhaps annuals. And it's still not enough time. 15 minutes wasn't enough time. Wasn't enough time for me. I was spending a lot of time blocking my schedule because I knew my patients needed more time than 15 minutes. So what the pilot program was is, you know what, let's just get rid of the 15-20. We're going to go to all 30-minute appointments, and we're going to take out blocks. We're going to take out just 30-minute appointments. That's it. Whatever the hours are that you normally work, and absolutely no 15-20. So what that did, and what that can also do, is it takes away any need for triaging by anybody else on the phone to know, well, is this a 15-minute or should this be a longer appointment? Takes all of that out. So anybody calling in, you make an appointment, you just get it for the 30 minutes, no questions asked. What some of the benefits are, of course, more time with patients, more time for cognitive reasoning. There actually was potential for higher RVU, and I'll go through some of our data. Ability to do more of the preventive care. So we might have more time to talk about getting vaccines or smoking cessation or some of these other, getting their mammograms, whatever that may be. We actually had a lot more control over our schedule. There was improved clinician satisfaction, and there was also improved MA satisfaction. Next slide. And just to sort of point out what some of the things we had already available before we did the 30-30. And so this was my practice, so it may not be all of yours, but we had already done a lot of waste reduction by using the lean principles. We already had standard rooming processes with the MAs. As I mentioned, all the exam room had the exact same things in it. There was co-location with the clinicians and the MAs, so we were in our own pods right next to each other so we could do huddles. We were already working on electronic health record templates and best practices. We already had e-prescribing for all of our medications, including controlled meds. We had our state prescription monitoring program already embedded in our EHR. We had allied health professionals, so the PAs and nurse practitioners, doing some of our indirect care coverage with the inbox. And then we also had pharmacists and nurses to help us co-manage diabetes, chronic pain, blood pressure, and others. Next slide. But we still didn't have enough time. So what we did is we did get approval. So I did work with one of the supervisors in the clinic who really, I think, walked the talk of clinician well-being. And he agreed to, have us try this pilot. We started with 4 physicians, and then we added very shortly another 5. So we had 9, and it was all physicians here, but we had other allied health professionals out of about 22 clinicians. So 9 out of those were in the pilot. And then I actually said to the administrator, I said, look, I don't know what the things are that matter to the fiscal. So you figure out what those things are and you measure those. So we had data about RVUs and patient visits, and that was the data that he was collecting. Of course, it has to be adjusted for whatever time away is. And then I did a questionnaire before of all the clinicians. And afterwards, we also got feedback not only from the clinicians, but also from the medical assistants. And we compared the mini Z before and after with all the clinicians. Next slide. So because we had actually success with the first 4 clinicians, that's why they added the others relatively quickly. All of the clinicians reported improved well-being. 8 of the 9 clinicians did not feel that the number of patients they saw was that different, and that the monthly average RVU actually improved for 50% of the people in the pilot. Improved, not went down. There was 1 person who decreased, and the remainder actually was no change. Next slide. Again, just looking at the mini Z questions. So this is what we use to sort of measure satisfaction before and after. Next slide. And here were some of our results. So we didn't get everybody, but we got 21. And 88% were satisfied with their job now, which was an increase compared to those who were in the control. A much higher percentage of people felt they had more control over their workload, that it was manageable, compared to only 50% of those in the control. There's still more work to do on time for documentation, but it actually improved for those in the pilot compared to those without. And what that means is that there is less what we call pajama time or time at home doing documentation. And that was one of the goals of this, was to really be able to complete the work at work and not have to take anything home or disrupt anybody's home life or family life. Next slide. And here were just some of the comments, which I think are really valuable. I'm able to have better patient care. I have less documentation at home. I have time to do clinical reasoning. This has improved my work and professional satisfaction. I am more engaged with patients. I am less frantic and irritable. My medical assistant is happier, and I have more control. Next slide. And here are some of the comments from the MAs. Most of the messages are done and completed before I leave for the day. The clinician is not getting us behind. I'm happy that I don't have to worry the call center is not giving enough time. So again, this is taking away anybody else affecting the schedule. And I have time to address other concerns. The clinicians seem to be running more on time. And what one of them said was, the MDs felt very rushed on the 1530 and the 2020. Things would get missed, and then follow-up calls would have to be made, which actually just generates more work, especially into the inbox. Next slide. So a couple of the downsides, 2 of the 9 were not seeing as many patients. 2 of the 9 might have had lower RVUs. Some still didn't feel that the workflow or the work was getting done on time, but almost as many felt there were absolutely no barriers. And of course, future PDSAs, still too much indirect care. Next slide. So what this did is, so this data was actually presented by my administrative partner to the supervisors and the leadership of primary care. So this was across the entire organization, and presented the data in a way with all the data that we presented, with the improved satisfaction, with really the RVUs not being that much different and the patient visits not being that much different. And what that allowed was an approval of adding a 30/30 option to anybody in primary care. So it didn't take away any of the other options. What it meant was, depending on your practice, you could choose which kind of schedule you wanted. I would say the majority of people in primary care went to a 30/30. Certainly almost everybody in internal medicine did. But if you preferred a 15/30, you could keep that. You could do a 20/20, you could do a 20/40, and then there was another one, a 25/25. And then it also gives you the option to either add on, time or book double booking if you gave approval. So it wasn't an automatic thing. But that again speaks to the flexibility. So I know my practice. I had a mature practice. My patients needed the 30/30 time. Somebody else's practice may not need that, but it gives choice, and that is important. Next slide. And I do want to say that was in 2016. We did the pilot for 9 months and then presented the data. And since 2016, through all of COVID to today, there's still the 30/30 option. So it has persisted, and it has not necessarily caused any significant downturn in terms of patients or revenue. So getting back to what I call some of the 5 Ps or 4 Ps of organizational change is, 1, you need to have passion for the issue. So this issue of having more time with my patients, that was my passion. I had to have that. I had to stick with it. So I had brought this over and over again, more than once, and I did not think a no was a no. I said, okay, well, I haven't gotten to the right person to help make this happen. So I finally did. Persistence pays off. You got to stick with it. You may need to tweak it. You have to look at the data and call it a pilot program or PDSA. Next slide. And so when you're thinking about a PDSA, for those who are not very familiar with doing these are small incremental projects that you do a little at a time. And PDSA stands for Plan, Do, Study, Act. So you want to generate an idea. It's good, I think, to start on something small. Again, just so it's successful, and then you can build on that. You may need to get buy-in. And if it's going to be something where It could be about the electronic health record or something. Make sure you have somebody involved in that early planning that can help you with that. So that could be somebody in IT. So it may be somebody you don't normally think of to be part of the project, because their input is really valuable. You want to keep adjusting. So you try it, you do something, you look at the data, did it work, what didn't work, what worked, and then you adjust it. So those are those little adjusting until you get it right. And then you have to keep monitoring the outcomes. You want to try to maintain the gains. So if you do a little, you don't want to lose that. You want to try to build on that and keep moving forward. And then once you have actually gotten it to where you want, so my goal for the 30-30 was to get 30-minute appointments. So that was the project goal. We got it. Now we're going to move on to a different project. Next slide. And then you do have to also show, I think, again, the data. You have to show the outcomes, both good and bad, what worked, what didn't work. You need to quantify that nobody left the organization during this time. Most people were satisfied, so they weren't going to be looking for jobs somewhere else. And you want to see what quality improved. So one thing I didn't report on, because it wasn't actually part of the project, but there actually was more preventive care being done. So the people who were in the pilot were meeting more of those benchmarks for getting hypertension under control, meeting more of the benchmark for getting their patients their mammograms or their colonoscopies, because there was more time that was allowed for that. And then you want to keep, again, monitoring for improvements, not overdoing it, because we are all have way too many meetings and surveys. You don't want to overdo it, but you do need to do enough that you are actually monitoring to make sure that what you do works. Next slide. And I do want to mention that a lot of this is about positive psychology thinking and action. And that positive psychology is a lot of work done by Martin Seligman, who's at University of Pennsylvania. And he really talks about things as what he calls PERMA, which is positive emotion, engagement, relationships, meaning, and achievement. And I think when we think about the things that we want to do for our practice, we should probably have PERMA in mind, because doing something positive can actually impact all of these areas. And so I do think that system-based change is about positive change. It's about positive psychology. Because again, I love being a doctor. I love healthcare. And I want to be sure that myself and others can thrive in the environments that we work. Next slide. We also do want to make sure that we take care of ourselves. So I do think there are things we can do for ourselves that will help us out. So we need to make sure that we manage our own energy, take your breaks, eat with others. Don't sit at your desk typing with one hand, trying to eat with the other. Give your brain a break. It will work better. You need to make sure that if you do feel that you are struggling, get help. Please make sure that you don't get into emotional overload. There is help. It can be confidential, but it's really important that we also recognize, when we need to take some breaks and other things. Again, reframe things to a growth mindset. So I'm proud of what I did, and I'm going to look for ways to improve, as opposed to, oh my God, that was terrible. I keep a feel-good file. What I call that is these are notes, cards, letters, things that either patients, staff, or others have given me or sent me, just thanking me and telling me that I made a difference. And so I think that's really good, just to remind ourselves why we do what we do. We tend to always focus when we hear a negative thing, that we forget all of the positives that we have given. Make sure that you know what your personal commitments need to be. If you need to be home for dinner, picking up your kids at school, getting exercise, and again, try to have reminders why you went into this career. Next slide. So again, just to remind ourselves of what some of the quick wins are, remember your P's and Q's, especially the questioning assumptions. One person can make a difference. It will take others to help meet it, but you can be the impetus and the driver of change. When you're dealing with the C-suite, you do want to get some business language, and there are tools actually to help you do that. go for the easy projects first, and then make sure you get data before and after for this. Next slide. So Lao Tzu said, do the difficult things while they are easy, do the great things while they are small. A journey of 1,000 miles begin with one small step. Next slide. So these are just some resources. So American College of Physicians has free online tools. AMA has the steps forward. And these are all looking about different things that systems can do. So different other people's ideas and things that they have done. There's also several articles that you might want to read about. And that is the end of the talk. So I do want to we can take the slides away. And I just want to see if anybody has any questions. So I have my chat up.
I don't see any questions yet, but remember, you can put them into the Q&A box, the chat box, or use the raise hand feature and speak directly to Dr. Horwitch. And while we're waiting, I will just remind everyone that we are our own accreditor. So what that means is that you don't have to wait now to the end of the calendar year for your CME certificates. As soon as you do that CME survey, which is going to pop up when you close out of this webinar, within 4 weeks, you will receive your certificate for today's session. That does not mean anything for 2023. You'll still get that summary certificate soon. Question, do you have suggestions regarding pre-auth?
Yes, I have a lot of them. So please recognize that much of what I'm going to say is my own opinion. It is not that of MAVEN or any other organization. By and large, I think prior authorization, I can't remember when it was put into place. It was probably put into place for very specific procedures and some very, very expensive medications. What has happened to prior authorization over these several years is it's gotten out of control. So number one, my suggestion for prior authorization is if you can in your own states and with your own both state and federal representatives and Senate, you need to ask them to fight against it. And we've done this in Washington State. We got a bill passed. It's an uphill battle. It's not fast. But by and large, we need to actually reduce the amount of prior authorization. But things that are probably more immediate. So something we've tried to do is to have a standard form for prior authorizations. Unfortunately, a lot of practices have actually had to hire somebody just to handle this. And so that is something that if an organization can do that, is to just have a place like, okay, you write a prescription, you get a notice that it wasn't, that you needed a prior auth. Then we actually sent it to somebody who literally they did that all day long. But that is an expensive venture. Other things to think about is it's sometimes challenging, I think, depending on your electronic health record. So when you do e-prescribing, it is supposed to tell you if a medication that you are prescribing is covered under their insurance. So it's supposed to have a tier 1, 2, 3, whatever. That doesn't always happen. And so sometimes you find out after the fact that if you had prescribed this version or, instead of, captopril, you prescribed lisinopril would have been covered without a prior auth, whereas the one you prescribed was not. That's just very challenging. So if there's any way for somebody, usually we had our pharmacists do this to kind of help us tell us which were the medications that don't require prior authorizations, can be very helpful. So I think you really need your team. I think the bigger thing is doing the advocacy because we got to get rid of prior authorizations. It's costing our healthcare system a lot of money to do it. And I don't think it's saving it very much. That's my opinion only. Any other questions? That's an excellent one. And thank you for letting me talk about advocacy.
You don't see any questions, but we will obviously wait to see if any last minute ones.
Yeah. So I will say one of the questions that I get asked about the 30/30 is, well, how did you do that and not not reduce access issues. And what I would say with that is that really depends on how your clinic organizes their open slots. So at least one or two clinicians in our clinic sort of had a hold, usually for the afternoon, to handle somebody who called up that day who really needed to be seen if the other clinicians were already booked. We also had a system, a standard, where if somebody canceled and it was in enough time frame that another person could be put into the schedule, that it was agreed upon that we could just do that without asking the clinician. It was not overbooking or double booking. I want to be very clear on that because that's actually a huge stressor. But it is having an open slot to be available. Now, I know in clinics that may have a lot of no-shows that can be very challenging, but maybe that's a way to try to work at the system. And, maybe get some virtual visits in or something like that, where it's still revenue generating, but maybe less stressful, and less of a concern on the cost to the system. Any other questions?
We don't see any, but that was fantastic as well. We'll just wait one more minute. If you have any last minute questions, please type them in. I'll keep rambling about our new CME process. We're really excited to offer those certificates almost in time instead of waiting until after the calendar year. And just a reminder, it is a new year, new you. So if this is something that you'd like to learn more about, or you would like to do like one-on-one mentoring, we do offer mentoring sessions. Dr. Horwitch is my #1 mentor. But if you are looking for mentoring with time management or clinical case review, please feel free to fill out that request form.
Or even mentoring with how to do these PDSAs. You could also, if you want to use a different language, if you call this quality improvement, everybody is doing quality improvement. So that's another language term to use that resonates, especially with administrators and supervisors. So I'm happy to mentor people on how to do this.
Fantastic.
How would you frame? Okay, so number one, so this is where data helps. So thank you. The question was, how would you frame loss of patient access? I want to be very clear. In our practice, with our pilot we actually didn't lose patient access. So that is one of those assumptions that I think we need to question. The question was, well, if you go to this, you don't have as much access. In fact, we actually had the same amount of access. Most of the people in the pilot had the same number of patient visits as they did before it. One person went down and I think one was neutral. It's something you can monitor. Again, whatever your organization is using for the expected number of patients or whatever, if you are giving more time, then I had told them, I said, look, if I'm giving more time, if you're telling me that I am behind on patient visits or something, you tell me how much, and I will look at my schedule and figure where I can add that time to make up for that. I'm willing to do that because you're giving me something I need to be able to do my job. So I think that is an assumption that we actually lost patient access, but because we actually didn't when we looked at it. And I think what we need to realize is a lot of practices put in a lot of blocks to catch up when you have these shorter appointments. And so that, again, it doesn't really allow you to catch up because you still don't have enough time with the patient. So that just ended up being lost time. And when you took all that out, I was actually being able to get away for lunch when I went to the 30/30, whereas before I was working through lunch to catch up. So I'm not sure we actually lost. Now, that may be different for every practice. That's something that you would have to measure. But I think that's an assumption we have to question. Thank you for the question. Anything else?
Do you have any other scripts or frames that have worked well?
Scripts for how to phrase why to do this? Or what script are you talking about?
It just says, do you have any other scripts or frames?
I don't, it would depend on the situation. So, when I went to talk to my administrative partner, I actually had all the data from the burnout. And I said, I think we need to care about this because we know that those who are scoring very high on the burnout are likely to leave the job in the next couple of years. And I said, and I know that turnover is expensive. It's also hard on morale, and it actually will create more of a problem to get access because when you have clinicians leave, then you lose access. Other clinicians can't just make that up. So I had all that information, and I said, but most importantly, I think we need to make sure we are telling people that we are, working on bettering the system and, improving the healthcare system and improving working here, then we need to walk our talk. If we are going to say that we do that, we actually have to try these things and make sure we're actually doing it. So, but it would depend on the situation. But I use data and I use the notion that this is important for having our healthcare workers thrive.
Great, thank you.
Any other questions? These are great questions. Thank you.
I don't see any, but we'll always pause for that last minute and just make sure. All right. Well, I guess that's going to wrap us up. If you do have any last minute questions and you think of it afterwards, Dr. Horwitch is on our e-consult platform, so you can always message her directly and say help. But she'll be happy to answer any questions there as well. So thank you all for joining us today, Dr. Horwitch. Thank you for kicking off our 2024 Ed session year.
Thank you all so much. We can do it.
Yay!
And again, I'm happy to help people brainstorm for this if you need.
All right. Thank you so much. Have a great day, everyone.
Thanks, everybody. Happy New Year.